Thank you very much for the introduction. And I'm very glad that my duty is to do something more pleasant, which is to share the good news, rather than Eugene's duty, which to give you some bad news. So I will start from a publication very early this century. This is a very well-known publication on the Aspergillus mortality rate. And the news was very, very bad. At that time, they looked at more than almost 2,000 cases in the literature, and the death rate from patients suffering from invasive aspergillosis was very large. As you can see, 55%. And if the patient had had a bone marrow transplant, it was almost 90%, as was the case with those who had CNS involvement. But fast forward 7-8 years, and we have these data from Livio Pagano's group in Italy. As you know, he runs a consortium of Italian hospitals looking at fungal infections in patients with hematological malignancies. And he wrote this letter to CID reviewing the improvement in mortality rates in survival of patients with invasive aspergillosis. So in the first period, from the late 80s to the late 90s, mortality was very high, close to above 40%, but it had progressively declined. Of course, the denominators are not comparable. You know, the latest publication was only from 2006, but basically he attributed it to the increasing use of newer antifungal agents, in particular voriconazole and the echinocandins. That's our study from AFWG. We looked at all the. This was all mold, so not just invasive aspergillosis, and we had a case mortality rate at 90 days of about 30%. So again, I would think that's quite a good figure because this is not just aspergillus, but also mucor and a variety of other unusual fungi. So I think the news looks like it's going to become better. I'm supposed to talk about new antifungal agents, so I will delve straight into the new kid on the block, which obviously is Isavuconazole. And I'll spend some time on the two big studies which won for the drug FDA approval. So the first is the SECURE study, where Isavuconazole was trialed against voriconazole for invasive aspergillosis, primarily in patients with hematological malignancies. And no matter how you cut or slice the data, whether it was the intention to treat analysis at day 84 or day 42, or whether you had people who had at least one dose of drug, or whether you took those who actually had proven or probable invasive aspergillosis, it met all the non-inferiority criteria for all-cause mortality. And if you look at the safety data, it was even more impressive. We've all used voriconazole for many, many years. It's actually been a boon to those of us managing compromised patients, especially on the hematology unit. But Isavuconazole looks safer, at least from this study, with statistically significant differences in terms of the cutaneous, ocular, and hepatic side effects. So the data were considered so impressive that in this year's European guidelines on the management of invasive aspergillosis, the Europeans gave it an A1 grading. But of course, primarily for those patients that were included in that big SECURE study. For other patients who might suffer from IA, such as those having had a solid organ transplant or those with HIV, the European Society still stuck to voriconazole, although A3, because obviously they were underrepresented in the big studies. So the next study was called VITAL. This is Isavuconazole for mucormycosis, a very interestingly designed study. As you know, mucor is a very rare disease, especially if you want to satisfy strict research criteria, such as those proposed by the EORTC. So it was not randomized, it was actually single arm open label, but they had a comparator arm. They used Fungiscope data. So Fungiscope is a database to which international collaborators contribute data on patients with a variety of fungal infections, mucor being one of them, and also send isolates to a central lab. So they were able to, they looked for matched comparators, 3 for each case that was given isavuconazole, and they matched based on these criteria: severe or not, severe being defined as CNS infection or disseminated, hematological malignancy or not, and surgery or not within the first 7 days. So there were 37 patients with mucormycosis, and these people received it for a variety of reasons: for primary treatment, refractory to other treatment, and intolerant of other treatment. And here are the baseline data. This was not a randomized study, so there were unfortunately some differences, and some may or may not have acted against the comparator arm, almost all of whom were given amphotericin. So lots of whites in the amphotericin arm, but not too bad, more or less comparable. The amphotericin arm, as you can see, actually had a smaller, had more people with pulmonary only involvement, suggesting that perhaps that would have benefited the amphotericin arm. But these are the data. If you look at crude all-cause mortality, there was no difference between the 2 arms. I think it's easier to look at survival, so I've looked at it like that. So all-cause mortality, survival at day 42 was 65% in those who receive isavuconazole. Then if you go out to day 84, which is 3 months, that's 59% survival. So is this good enough? I look at the literature. The Europeans have published the Fungiscope data based on 41 cases. Overall survival was 51%. You might know the DEFEAT study, where ambisome was tested against ambisome plus deferrasurox, and this was a study which really showed that it was bad to add deferrasurox. But the ambisome only arm did very well, 89% 1 month survival, but of course the numbers are very, very low. 1 additional death would have brought it down 11 points, as you can see. And then of course there was the high dose ambisome study, 10 mg per kg, also very much talked about at fungal conferences, where they had 1 month survival 79%, 3 month survival 62%. So 62% is more or less the same as 3 month survival with isavuconazole, which in the previous slide, as you can see, was 59%. But there was a great cost, of course, to using ambisome at 10 mg per kg. 40 or plus % of the patients had a rise in serum creatinine. So basically, this is a new drug, so maybe you need some PKPD information. It's available in both IV and oral formulations. Excellent oral bioavailability, so no need for dose adjustments between IV and PO. Very interestingly, absorption is not affected by food nor by drugs, so we know that there are interactions with omeprazole, of voriconazole and posaconazole. Renal impairment does not affect either the maximum concentration or the area under the curve, although hepatic impairment will reduce clearance. It doesn't appear in the urine, so like many of the other azoles, it cannot be used for urinary tract infections. But the IV formulation has no cyclodextrin, which obviously will become an advantage. The next question is whether or not TDM is necessary, and these investigators had a chance to look at drug levels amongst some patients in the SECURE study who consented to have blood taken for the PK arm of the study. And as you can see, in terms of AUC, or in terms of steady state concentration, there actually was no correlation between those who had successful use of Isavu versus those who didn't. So interestingly, levels seem to be a little bit lower in those with clinical success. So this is not quite well understood. Was there a lot of non-compliance? Of course, this is a clinical trial. Patients are closely monitored. It looks like there was no evidence for this. It may be that there is indeed a dose-response relationship, but the results we are seeing are in the top end of that S-shaped curve. So everybody was in the plateau. But basically, these investigators, I think they're mainly from Wisconsin, suggested that it was probably not necessary to do isavuconazole TDM, suggesting that maybe it is necessary only in certain circumstances, like if absorption was in question, say someone who had graft versus host disease, or if you were treating CNS disease, in which case you wanted to be assured about levels. However, these French investigators found 4 patients with extremely high levels of isavuconazole in the blood. I think these graphs depict them better. So the gray curves are the population PK, 5th and 95th centile from that earlier Desai study, taking from patients from the SECURE trial. And then their patient's level was very, very high. So it's here. It's above the 95th centile. It's here. This person had 2 levels at about the same day. So, and basically it took some time to do dose adjustments, and even then it came down. In this study, they also looked at the pharmacogenomic profiles, and they could not find polymorphisms to explain this. So they were very gentle in their conclusions. Instead of saying outright that TDM was needed because they only had 4 patients, they suggested diplomatically that maybe we should collect 1 blood sample just before the first maintenance dose to see what the levels were like. And if it did not fit the population PK, as in the published study, it was probably useful to do some TDM and make sure that levels were within the therapeutic range. So drug interactions, it's an azole, so we can't escape from the usual problems with warfarin, with the statin, with the CNIs like cyclosporin and tacrolimus, and of course be extremely careful. Rifampicin, as usual, will wash away all your azoles. And unsurprisingly, people have used it against mucormycosis with success. They've published some of these papers, and I think we can look forward to increasing use of isavuconazole. We really need more data. We don't know whether there are certain species that would be resistant. So now, would you prefer isavuconazole or voriconazole? So there are some advantages of isavuconazole. I think one of the most important would be the absence of this cyclodextrin vehicle. For a long time, multiple papers have suggested that this might accumulate in patients on dialysis. So in the absence of cyclodextrin, you can probably use it without worries in someone who was on hemodialysis. Favorable side effect profile, as I showed you a few slides ago, and very interestingly, no QT prolongation. In fact, it shortens the QT interval. Of course, we only have a very small experience with it. It's not been launched in many countries. India, I've just heard, will be the first country in Asia to launch it. We have already managed to obtain it, to use it, and hopefully there'll be an opportunity to share our experience in future conferences. So because we have managed to access isavuconazole, I've had to think in my mind how we would best use it, and I share this personal approach. It doesn't come from any publication. There's no reference here. Please feel free to suggest how we can improve this approach. So if you had a compromised patient with a halo and with a nodule, perhaps with a halo, then it depended on whether this was more likely Aspergillus or mucor. So if aspergillus is suggested, perhaps BAL galactomannan is high or it's already growing something that looks like aspergillus. Voriconazole, I think, should be drug of choice, mainly because of our very large clinical experience with voriconazole and with multiple publications suggesting that the use or introduction of voriconazole in their unit, in their country, was associated with dramatic increases in survival. But of course, you can use isavuconazole in certain conditions, like if your patient had a very prolonged QT, especially if he or she also had episodes of arrhythmia in the past. The patient was on hemodialysis and you were uncomfortable about the fact that the cyclodextrin vehicle in voriconazole would accumulate. On the other hand, if you had some inkling that this was going to be mucormycosis, for example, there was a reverse halo sign on the CT, then I would think that we should stick to liposomal amphotericin as drug of first choice. But again, I think there's enough data to use isavuconazole if this was a person with a creatinine of 200 or 300, and if you spoke to him and he really, really needs to preserve, feels that he should preserve his renal function. So there are these issues where you might, there are many niche scenarios in which isavuconazole may well be used up front, but I look forward to more input on how we could improve this approach. So now I want to move to yeast, and here there's been a whole load of good news over the past 15 or 16 years, as most of you would know. The good news, of course, has been led by the introduction of the echinocandins. These are just some of the publications. There's also one on micafungin. So this was the earliest, 16 years ago, caspofungin's introduction trialed against amphotericin, which was then a gold standard in candidemia. And these are the impressive results. As you can see, I've put them in graph form. Where's my graph? Oh, did I lose a graph? Okay, anyway. Basically, we can see that with caspofungin, success was 73%, one of the best success rates for all candidemia trials historically, because the amphotericin arm at 61% was somewhat more conventional. I think with the John Rex studies for fluconazole had almost 70%, 67, 68% success. And if you do look at the Riboli study on anidulafungin, these are the results, largely favoring anidulafungin. In fact, many people analyzing these data have actually said that anidulafungin proved itself to be superior to fluconazole. And we don't need to go through the fact that in the anidulafungin, the two arms are very well matched. And there's this meta-analysis also very much quoted at fungal conferences, indicating that survival in candidemia was independently predicted by treatment with an echinocandin as well as early removal of the CVC. And this is just a graph to show that receipt of an echinocandin had a favorable impact on mortality in the first two Apache quartiles. So I'll just go through with you the evolving guides on candidemia from the various international societies. Generally, may have been confusing, but generally good news all the way. So in 2009, this is the IDSA guide giving an A1 rating to all those studies that was all those drugs that were supported by at least one RCT. So A1 for fluconazole, A1 for an echinocandin, A1 for conventional ampho, A1 for a lipid formulation, and A1 for voriconazole. But in 2012, the Europeans decided to be novel, and they gave A1s to all the echinocandins and downgraded fluconazole, which for the longest time had been the darling of many ID physicians. And they explained themselves mainly from the data resulting from the Riboli study on anidulafungin. They felt that fluconazole had been outdone by anidulafungin at many time points in the endpoint analyses. It also succeeded across a very wide range of Apache scores. And of course, theoretically, we know that fluconazole has no efficacy against Candida krusei. Lots and lots of glabrata are actually SDD or resistant, but annular fungin was effective against all of these. So for these reasons, although supported by RCTs, fluconazole received a C1 rating. So this is the most recent guide from the IDSA. Yes, indeed, they recommended echinocandins as initial therapy, but felt that fluconazole was an acceptable alternative in certain categories of patients, especially those who would not be predicted to have an azole-resistant candida. But perhaps they have not seen Eugene's data on Candida tropicalis and the environment. But anyway, yeah, so as for the lipid formulations of ampho, only if there was intolerance, resistance to other agents, and they felt that voriconazole offered little advantage over fluconazole. So the guidelines have evolved. Basically, you're not wrong, no matter what you use. So on the whole, I think the news is good. So although now the candins have become very popular, I'm sure they've added to a fair bit of increasing healthcare costs, but they're not perfect. And in particular, when you handle immunocompromised patients. So I think breakthroughs are very common, or rather breakthroughs are very well documented, primarily in compromised patients who have very weakened immune systems. So in this case report, there are all these people failing a transplant with graft versus host disease, ongoing immunosuppression, prolonged neutropenia, long periods of either Caspo or annular fungin, and when they had the breakthrough fever, blood cultures revealed either Candida parasilosis or Candida guillemondii. And if you look at series on trichosporonemia, then you find that trichosporonemia tends to be a breakthrough infection, and of those suffering a breakthrough, more than half would have had exposure to an echinocandin. And this is a report from one of my colleagues on trichosporonemia, breaking through caspofungin use in another category of patients, liver transplant recipients. So this has been formally analyzed. This is Dr. Soon who will speak this afternoon. Candin breakthrough can occur whether it is used for prophylactic or therapeutic purposes. Interestingly, you need only to have been exposed to it for very short periods, like 12 days before a breakthrough happens. And I don't know why, but for prophylactic use, its exposure for longer periods would be associated with prophylaxis, with breakthrough. And breakthroughs can occur with any of these pathogens, generally known to be resistant to the candins, like trichosporin and fusarium, but also those against which the candins have got activity, such as Aspergillus and Candida. So why Candida? That's because you can classify Candida in terms of their susceptibility to the echinocandins, so things like Kefir, albicans, krusei, and glabrata are uniformly susceptible to the echinocandins with very low MICs, but then for parasilosis, Lusitania, and guillemondii, they have somewhat higher MICs. So at the time when I first made this slide many years ago, the clinical significance of these somewhat higher MICs was not known, but now we know that they can cause clinical problems in the form of breakthrough infections. And why are the echinocandin MICs higher? Well, there's this amino acid substitution in glucan synthase, and we don't have time to go into that. But anyway, so can you actually use an echinocandin safely in someone with Candida parasilosis? So this is the CandiPop study. It's a study of candidemia in a variety, 29, I think, Spanish hospitals, and they looked at the 194 patients with Candida parasilosis and looked at what predicted outcomes. So basically what they found was that the main predictor of bad outcome was this orotracheal intubation. The presence of shock probably trended towards significance, but initial therapy with an echinocandin was not a factor that predicted failure. So, well, this is a retrospective observation, and some people may still find fault with it, but at least it gives us some assurance that if you start treatment with an echinocandin and it turns out to be paracillosis, your patient is probably not going to do badly. You still have time to switch to an azole. So does this mean that if we received a phone call from the lab saying that there was a yeast growing, we should just reach out for an echinocandin? I think the answer is no. It is appropriate and prudent for you to find out what sort of yeast it could be. It could still be Cryptococcus, it could be Rhodotorula, it could be Trichosporin. So it depends on the clinical context. If someone were to come from the community and he was very thin with zoster scars, this might be someone with HIV infection, and that yeast is likely to be a Cryptococcus. It would be inappropriate, of course, to reach for an echinocandin. So the main thing is to speak to the lab and to look at the clinical context in which this yeast is appearing in the bloodstream. And this is one of our AFWG studies. This was just published. We looked at all the non-candida yeasts, and about 8% of yeast in blood cultures were actually non-candida, with things like Cryptococcus, Trichosporin, Rhodotorula, all having reduced susceptibility to an echinocandin. So despite all the good news about the echinocandin, a very favorable side effect profile, very high efficacy against candidemia, I think it is appropriate that we exercise some thinking when we respond to a report of yeast in blood. Now, in the remaining time, I will go to prophylaxis in hematological malignancies. Also, generally, the news has been good over the past 15 years or so, led by posaconazole. So this is the famous Cornell study where posaconazole was trialed against either fluke or ITRA in patients with hematological malignancies undergoing chemotherapy, and as you can see, outcomes were much better for those in the posaconazole arm. But there were many problems with the then syrup formulation of posaconazole. Diarrhea, mucositis would markedly reduce bioavailability. Plasma levels were very low, and this was associated with breakthroughs. And then, if you also gave omeprazole, you will reduce levels dramatically, and I think one of my colleagues has a case report on that. So we did a network meta-analysis because there were all these competing aims and competing studies, and basically posaconazole was more effective at preventing aspergillus than placebo, than fluke, than ITRA, or than VORI. But in terms of preventing mortality, posa was more effective than fluconazole and ITRA. Voriconazole actually was more effective than others at preventing mortality, but posa and VORI were equal. But it's a question of willingness to pay because somehow posaconazole was more expensive than ITRA, but voriconazole was horrendously expensive. Now again, we have a problem of breakthroughs. So there's breakthrough rhizopus following posaconazole prophylaxis, breakthrough scedosporium. These, I suppose, are to be expected. And why do breakthroughs happen? So this is some French data where they looked at all those receiving posaconazole prophylaxis. These were from the data, you know that these are suspension. So breakthroughs were Aspergillus, Candida glabrata, Fusarium, Zygo, and most of the time it was lowish MICs. Yeah, so posa level below 0.3 was an independent risk factor for an IFI. So low posa levels, yeah, mainly because of diarrhea and mucositis. And I wonder which hematological malignancy patient going induction remission chemotherapy doesn't have that. How to maximize posa levels? Take with food, in particular fat, but I don't know whether if you're vomiting and bad mucositis from IA3+7, you can actually take much of fries and Kentucky Fried Chicken. But the good news is that we now have a tablet formulation, and the tablet has many advantages. It's probably not affected by acid suppression. There's a single study, but healthy volunteers. But in the real world, here are 2 studies from the US. Tablet posa does achieve better levels than the syrup. So you can see that the steady state concentration were all higher for tablet. But these are all real world data. The investigators didn't go out to define the time of collection, etc. So have to be taken with a pinch of salt, but at least they are real world conditions. Finally, of course, in terms of the therapy for prolonged febrile neutropenia, the news is also good. We've resorted to amphotericin and lipid formulations for many years, but this study, I think from Tom Walsh, indicated that caspofungin was just as effective for this purpose and very much safer. But actually the news with respect to how to approach persistent fever in prolonged neutropenia is good, not just because of caspofungin, but also because we have all these newer approaches. So the news doesn't just come from new drugs, but also from the fact that newer or existing diagnostic modalities are being used strategically. So we have galactomannan, we have the use of HRCT, some labs have access to an aspergillus PCR, and because of that, people suggested that you could move away from universal empirical antifungal therapy in the setting of persistent febrile neutropenia. So various terms have appeared to describe this sort of approach: a tailored approach, or clinically driven diagnostic approach, or preemptive approach. So I don't have time to go through all that. It's actually the stuff of one whole lecture. I think you may find an old lecture of mine at the AFWG website. But basically, this is, in sum, the tailored algorithm, an algorithm to the tailored approach. So if your patient had shock, that's most likely to be candidemia, so caspofungin or ambisome. But if you had a focus that was in the lung, maybe you would resort to voriconazole. But if there was no shock and the patient was very stable, you can actually embark on a series of enhanced diagnostic testing, such as doing blood fungal cultures, doing the galactomannan if the patient was not on an azole, doing a CT thorax, and performing other investigations as dictated by symptoms and signs. So this is an algorithm proposed by the Spanish, and I'm quite sure that this will undergo changes because now we have the isavuconazole to somehow fit into the equation, and the algorithms, I suspect, can only become more complex. So in summary, I think I have had quite a fair bit of good news to share. We don't have as many drugs as our fellow practitioners in HIV medicine or in the care of hepatitis C, but at least we've got the echinocandins with the excellent side effect profile. I think isavuconazole is going to be an interesting addition to the armamentarium. We can probably treat more niche categories of patients, and posaconazole for prophylaxis and the improved tablet formulation promises to make chemotherapy for our patients a smoother ride. And finally, of course, with more drugs, we can think of more refined approaches to the problem of persistent febrile neutropenia. Thank you very much. I still have 1 minute to spare.
Thank you very much.